عدة مرات، لكن لم ينجح أي منهم في أدائه. هل هذا السبب؟ هل السبب هو قيادتهم؟ طبعا لا، الرغبة موجودة والطريق معروف. السبب عدم تمكين القطاع هذا في الواقع، وعدم وضع الآليات الصحيحة والحوكمة الصحيحة التي تمكن الرعاية الأولية من أخذ دورها الأساسي. نحن نشتكي في المملكة في الواقع أن الهرم لدينا مقلوب، بمعنى أنه 70-80% من الخدمات بتقدم في المستشفيات، حتى خدمات الرعاية الأولية وخدمات الارجنت كير وخدمات سكرينينج، ويعني كل شيء تقريبا يقدم في الفيرست ستوب هو المستشفيات الثانوية إذا لم يكن المستشفيات التخصصية. التحول أجانا الآن بفرصة كبيرة لتعديل الوضع، بحيث أن يكون فعلا 70-80% من العمل يقوم فيه في الواقع اللي يقوم فيه هو البرايمري كير والطبيب العائلة والفريق اللي يحيط طبيب العائلة، بحيث أنهم يكونوا مسؤولين عن صحة الإنسان، مسؤولين عن المحافظة عليها، مسؤولين عن اكتشاف المرض مبكرا لو كان لا سمح الله حصل، ومتابعته، ومسؤولين عن أخذ المواطن في طريقه الشائك في المرور بمستشفيات مختلفة أو تخصصات مختلفة في مستشفى واحد. إذن ما في اختلاف. نحن بحثنا مع برنامج التحول الوطني، طبعا اللي هو بدأنا فيه، كنا ملف واحد في برنامج التحول الوطني ال5 سنين الأولى اللي هي من 2016 إلى 2020. كان الموضوع هو في الواقع كان مجموعة ملفات ضمن ملف برنامج التحول الوطني. كان الموضوع كله يعنى بوزارة الصحة، بمعنى أن وزارة الصحة كانت تقدم الخدمات الصحية وتمولها وأيضا هي تشرف عليها. الوضع هذا كان وضع غير صحيح، وبالتالي كان هناك مجموعة كبيرة من المبادرات وصلت إلى 70 مبادرة. نصيب الأسد منها كان لوزارة الصحة وتغييرها، بحيث أن تصبح وزارة الصحة منظم تتخلى عن تقديم جميع الخدمات الصحية. وزارة الصحة اليوم لديها 280 مستشفى وحوالي 2400 مركز صحي. هؤلاء كلها سوف تنتقل، وبدأت الانتقال تدريجيا إلى شركة تسمى شركة الصحة القابضة والتجمعات، يمكن سمعتوا كثير منها. الآن في 11 تجمع تقريبا بدأ على الأرض. طبعا لم يصدر قرار مجلس الوزراء إلى الآن بأنها تكون شركة، فما زالت شركة تحت التأسيس. النقلة الأخرى الثانية اللي هي عملية بداية برنامج الشراء الاستراتيجي أو برنامج التأمين الوطني، عن طريق إنشاء أيضا شركة للتأمين الوطني، وهذه أيضا تحت الإنشاء الآن، لكن في فريق كامل بيعمل عدة سنوات بيعمل على أساسيات الشراء من ناحية الكوستينج والبرايسينج والريفينيو سايكل مانجمنت والكودينج والأشياء هذه الأساسية اللي لازم تكون موجودة قبل. كان هناك أيضا في برنامج التحول الوطني في ال5 سنين الأولى في ملف وزارة الصحة، كان هناك مجموعة أخرى من المبادرات، مثلا لتحول مؤسسة مستشفى الملك فيصل التخصصي إلى مؤسسة غير ربحية أو شركة غير ربحية. أيضا كان هناك مجموعة من الملفات تعنى بتحول السعودي FDA أو هيئة الغذاء والدواء، أيضا الهلال الأحمر والمجلس الصحي. كان مجموعة من المبادرات تعنى بتحولهم كلهم. انتقلنا في العام الماضي في الواقع في الموجة الثانية من الرؤية أو اللي هي المرحلة الثانية، انتقلنا إلى أنه أصبح هناك برنامج كامل يعنى بتحول القطاع الصحي بأكمله. كما نعلم أن القطاع الصحي الخدمات الصحية تقديمها تقريبا 60% منها مسؤول عنها وزارة الصحة، وحوالي 20% وبتتناقص أقل من 20% الآن بيقدمها القطاع الحكومي الآخر. حوالي في عندنا 6 قطاعات حكومية أخرى، عسكرية وجامعية والهيئة الملكية وغيرها، تقدم خدمات صحية لمواطنين سعوديين، وهي كلها يعني تأخذ ميزانياتها من وزارة المالية كميزانيات. البرنامج في مرحلته الحالية يعنى بوضع استراتيجية تشمل القطاع الحكومي الآخر أينما هو متجه، هل نستمر بوضعنا الحالي أو يكون في تغيير أيضا في شكل القطاع الحكومي الآخر، بعد ما تم تحديد الآن رؤية بالنسبة لوزارة الصحة وتحولها. الآن ننظر في القطاع الحكومي الآخر، وأيضا في القطاع الخاص. القطاع الخاص نعرف نحن اليوم أنه أيضا هو قطاع للأسف يعني قائم مثل الوضع الصحي القائم عندنا في الببليك سيكتور، قائم على المرض وليس قائم على الوقاية والعلاج. بمعنى يعني المستشفيات الخاصة بتعمل مثل المستشفيات الحكومية على معالجة المرض، يمكن عندهم انسنتيف أكثر إنه المريض يستمر في المراجعة ويستمر يأتيه مريض بحالات متقدمة من المرض. فلازم يكون هناك أيضا تحويل القطاع الخاص اللي حيكون فيه طبيعيا بحسب رؤية المملكة إن شاء الله، في مثلا أنه الرياض تصير ميجا سيتي تصل إلى 20 مليون تقريبا يعني مواطن، أيضا 30 مليون زائر ومعتمر. كل هذا حيكون يزيد من الأعباء على القطاع الخاص، والقطاع الخاص حينمو بالتأكيد. وأيضا في خلال نموه هذا لازم نحن نميل البوصلة حقته أو التوجه إلى أنه يكون مور أو توجه أكثر توجه وقائي. نموذج الرعاية في نموذج قائم على الوقاية، يكون سنجل بوينت اوف انتري أيضا للعاملين، تكون البوليصة التأمين يعني تشمل الوقاية لا تشمل فقط العلاج. فنحن نريد في الواقع كمنظومة الآن أو كبرنامج للتحول القطاع الصحي أن نحوله إلى نظام الفاليو بيز هيلث كير أو نظام الرعاية الحكيمة. وهذا إن شاء الله يعني فيها مجال كبير للتحدث. لكن اليوم في مجالكم وفي الأمسية الجميلة هذه، أولا أشكركم على دعوتي وتشريفي بهذه الدعوة، وأتحدث إليكم من القلب. أقول أن أنتم الأساس إن شاء الله للمستقبل، يعني اليوم والمستقبل أيضا. لا يمكن أن ينجح المنظومة الجديدة إلا بتمكين الرعاية الأولية، بتمكين طبيب العائلة، بإيجاد حلول يعني من الآن إلى أن نستطيع يكون عندنا أطباء العائلة يمثلوا أكثر من 50% من أطبائنا. إلى ذلك الوقت لازم نعمل على خيارات وبدائل تدريجية ومنها أشياء فورية حتى نستطيع إن شاء الله أنه نحول نظامنا إلى مور فاليو بيز هيلث كير، نظام قائم على الوقاية، نظام قائم على الصحة والعافية وليس قائم على المرض. أشكر لكم يعني أنشطتكم في هذا المجال، ونقول الآن هو وقتكم. نحن واجبنا في البرنامج أن نعمل الآن على تصميم آلية ومنظومة تشمل من التمويل إلى الحوكمة إلى التشريعات، تضمن الرعاية الأولية تكون هي فعلا منطقة الدخول للخدمة الصحية، وتكون أيضا مسؤولة عن صحة المواطن كما ذكرت. وهذا النموذج هو اللي بدأ تطبيقه في التجمعات، ولأنه لم يمكن بشكل كامل وحيث بسبب أنه الأنظمة والتشريعات الآن لم تصدر قراراتها بشكل نهائي. فأكرر الشكر والامتنان، وأكرر الدعوات لكم بالتوفيق في محفلكم الليلة وفي كل ليلة إن شاء الله، والمستقبل كله لكم إن شاء الله، وللمواطن السليم المتعافي الصحيح إن شاء الله، للتمتع بالوطن وخيرات الوطن هذه وهو في وضع أفضل إن شاء الله. شكرا لكم وحفظكم الله جميعا.
السلام عليكم. شكرا دكتور خالد يعني على كلماتك ودعمك اللامحدود للتحول للكورنر ستون حق التحول اللي هو البرايمري كير. We are full of trust. I wouldn't say hope but trust بالتالنت اللي عندنا في البرايمري كير، the capability to make the transformation reality. And actually يعني النخبة اللي معاي tonight represent يعني some of the talent that we have nationwide. قطاع الصحة، ذكرت البرايفت، ذكرت العسكري، ذكرت الجامعي. And it's an honor to have a representative from each of these sectors that you presented today. I'm going to call the friends to my colleagues, the respected panel to themselves and what sector they represent, and then we'll start our أمسية. Dr. Amra, I'll start with you. Dr. Amra.
السلام عليكم ورحمة الله وبركاته، وأسعد الله مساكم. شاكر الأستاذ دكتور خالد، وتعاملنا معه سابقا في المشروع الوطني، وكذلك شاكر لكم دكتور سعيدة على الدعوة، دكتور هادي على الدعوة الكريمة والتنسيق الرائع لهذه الأمسية اللي هي واحدة من جميلة من عدة أمسيات مشابهة. اسمي عمرو جمال، وممثل قطاع التعليم في جامعة الملك سعود، رئيس قسم طب الأسرة والمجتمع في جامعة الملك سعود.
حياك الله يا دكتور. لعلنا ننتقل إلى القطاع العسكري. دكتور سعد.
السلام عليكم جميعا، مساء الخير. شاكر للدعوة الكريمة في هذه الأمسية الرائعة، أمسيات قمة طويق. أخوكم سعد البتال، استشاري طب الأسرة. مدينة الأمير سلطان الطبية العسكرية، الخدمات الطبية، وزارة الدفاع.
دكتور لعلنا نسمع من وزارة الصحة دكتور عبد العزيز.
أهلا وسهلا، السلام عليكم، مساكم الله بالخير جميعا. أنا أخوكم الدكتور عبد العزيز المطيري، استشاري طب أسرة من أكاديمية طب الأسرة بالتجمع الصحي الثالث بمنطقة القصيم. حياكم الله جميعا، وشكرا دكتور هادي على الدعوة الكريمة وعلى تنظيم مثل هذه الأمسية الرائعة.
حياك الله يا دكتور. طبعا معانا دكتور مها العطا، لكن الديسكونكتد شي وريكونكت برضه من وزارة الصحة، ولعل القطاع الخاص له يعني نصيب الأسد من الليلة. دكتور عبد الله الخنيزان من الكينج فيصل سبيشاليست.
السلام عليكم جميعا، يعطيكم العافية. أعتذر منكم أيضا، الرياض غير مع موسم الرياض، فأنا طلعت شوي متأخر من المستشفى ومسكتني أحمد. حياكم الله جميعا. وحقيقة كلمة ضافية من الدكتور خالد الشيباني. الدكتور خالد بالمناسبة كان هو المدير الطبي للمستشفى الملك فيصل التخصصي أول ما التحقت به، فحقيقة كلمات يعني رجل فاهم ومتفهم يعني تفاصيل التخصص وأهميته، وحقيقة مستبشرين خير ومستبشرين بهذه الأمسية، وحياكم الله جميعا. عبد الله خنيزان، مستشفى المركز التخصصي، دايركتور اوف امبيلاتوري كير سيرفيسز في التخصصي.
حياك الله دكتور عبد الله. ناو الى قطاع خاص اخر، الدكتور سعيد القحطاني من جون هوبكنز ارامكو هيلث كير.
مساكم الله بالخير. مساء الخير ابو عبد الملك، مساء الخير لجميع الاخوان المشاركين في الندوه، مساء الخير لجميع الحاضرين لهذه الامسيه الجميله، احدى امسيات قمه طويق. لي الشرف اني اكون هذه ضيفك ثاني مره لابو عبد الملك. استمعت لكلمات الدكتور خالد الشيباني، كانت صراحه يعني محفزه جدا، very inspiring speech. هذه ثاني مرة يعني أشوف الدكتور خالد، مرة قابلته in person والمرة هاي في الأمسية. كلامه محفز جدا ومحفز لقطاع الرعاية الصحية الأولية. أتمنى أن نستمتع الليلة وأن نقدم شيء للزملاء وللأخوان والناس اللي متابعين، شيء يعني يفيد ويحفز للمضي قدما. فشكرا أبو عبد الملك. أنا طبعاً سعيد القحطاني، رئيس خدمات الرعاية الأولية في جون هوبكنز أرامكو هيلث كير، المدير الطبي في مستشفى جون هوبكنز.
حياك الله أبو محمد. الدكتور طارق بن هية.
السلام عليكم ورحمة الله. شكراً أبو عبد الملك. أنا الدكتور طارق بن هية، فاميلي ميديسن كونسلتنت وكلينيكال إثيسيست. لي الشرف أن أشارك في هذه الأمسية الجميلة. بحكم أبو عبد الملك حاصل على highest patient satisfaction score in the last 2 years، وهذا شرف بالنسبة لي إني أخدم مرضاي، وإن شاء الله بنتكلم عن هذا الموضوع، وأتشرف أن أشارك الزملاء الأعزاء في هذه الأمسية إن شاء الله.
شكرا دكتور مها. you're representing to very important وزارة الصحة والمجلس العلمي لطب الأسرة. دكتور مها حياك، introduce yourself.
يا هلا، الله يحييكم. أنا دكتورة مها عبد العزيز العطا، نائب رئيس المجلس العلمي لطب الأسرة، former program director of the joint program of postgraduate studies of family medicine جدة، ويعني I'm a proud graduate of the joint program also of family medicine جدة. I'm very interested and I love family medicine, and I'm so happy إنه transformation 2030 يعني has involved and put us as family physicians in the core of the whole transformation process. Very happy to be with you all.
ألف شكر دكتور مها. بالنسبة our great attendees, please to ask the question through the Q&A. I'll summarize the question to our panel, and let's hit the ground running. دكتور سعيد القحطاني, primary care, why is all about primary care? We'd love to hear from you, Mohammed.
Thank you, Abu Abdul Malik. Again, I'm just trying to share my presentation here, Abu Abdul Malik. 1 second. Okay. So why primary care? This is a very critical question that we have to answer. Yani. We have to show non-primary care and primary care the evidence and why we're doing primary care. I think we are talking about it, and we have to tell people it's not only a passion because our bias or specialty that we're biased to. I think there is a very strong evidence, and I think Abdul Khanizan, the guru of evidence, is with us tonight, and he could maybe challenge me. So there is enough evidence to tell healthcare sectors or healthcare decision maker about primary care and why we are moving into primary care led models. Why primary care is priority for Saudi Arabia? You know, the burden of chronic disease is increasing with time. Yani it was like 15% of the people will have a chronic disease by 2030. 23% of the population would have at least one chronic medical condition. Increasing cost of healthcare. I think if we continue on the same burden of chronic disease, would maybe consume 30-40% of our budget. Waiting time to see a specialist is getting unbelievable. Increasing hospital bed utilization. Increasing emergency room, to the degree that sometimes they put beds in the corridor in the emergency room. Overall patient experience, lack of national program for prevention and early detection. Most cases are reached to the hospital with a late stage of cancer or coronary artery disease or death from coronary artery disease that are not detected. Need for population health data to plan for the future. So, and currently, I've been in accountable care organization workshop because we want to move our organization into an accountable care organization, and all the models that we have reviewed were dependent on primary care. There is a model in Spain that did not put primary care as in the foundation of their accountable care. And it fails. That model failed, and they have to reconsider. And then when they re-engineer their accountable care, it's called Alzera in Spain. The program actually had a great success when they reintroduced primary care to the model. So accountable care organization is about like cost containment, prevention, access to care coordination, quality of care, improving quality of care, improving patient satisfaction, and having an accountable care. So, the evidence showed the following: the supply of primary care had improved the outcome, and this is we have no doubt that in US, for example, states that has higher primary care ratio to the population has better health outcome, including lower rate of all-cause mortality. The supply of primary care physician is associated with increasing lifespan and even reduced low birth weight rate. Supply of primary care also, in addition to that, are associated with lower mortality, even compared to specialist care. Even when you compare to specialist care and primary care, people who receive their care at primary care are having lower mortality. The primary greater supply of primary care reduced the burden of chronic disease by from heart disease and cancer by significant number of percentage. In England, each additional of one GP only, which is around like 20 to 15 to 10,000 population, like 15 to 20%, was associated with about 6% decrease in mortality. And it has also the similar number in the United States. I'm sure most of you are familiar with the publication that was published recently in JAMA, where they studied the population for a period of time, and they have noticed that additional of 10 practitioners per a population of 100,000 was associated with 51 days of increased lifespan versus 19 days for the people receiving care at the specialist. And also they find that they have a significant reduction in cardiovascular cancer and respiratory mortality. I don't want to take all the time, Hadi. These are just a snapshot from certain study. If I've exceeded the time, please let me know. In Spain, when they reformed their primary care, they were able to reduce mortality from hypertension, stroke, and lung cancer when they study their effect on 10 years. And even poor country like Cuba and Costa Rica, who reformed their healthcare system to be dependent on primary care, have much lower infant mortality compared to other Latin American countries. So when they, there is a good system in Costa Rica and Cuba where they build a good primary care despite there being, poor countries. I'll move into the impact on cost, and this is, I think, the decision maker like to speak about cost. The primary care is proving to be cost effective. A higher supply of primary care physician to the population has given a lower total healthcare cost. I'll show you, for example, the per capita expenditure in the United States compared to countries like Italy, Spain, and United Kingdom. See how much the United States healthcare system, which is not a well-established primary care system, it's mostly dependent on specialists, has maybe more than double the cost of the countries that are dependent or have well-structured primary care like Italy, Spain, United Kingdom, and South Korea. And see, I think it's even exponentially going up in the United States, where it would consume maybe 20% of their GDP compared to the European countries. Access to care is highly improved with the addition or well-structured primary care, quality of care, and prevention, early management of healthcare and early detection of healthcare problem. I don't want to consume the time of my colleagues, but in all aspects of healthcare, the addition of primary care physician, a well-structured primary care, or moving toward primary care has a significant impact on those things, Hadi.
Thank you, Dr. Saeed. So bottom line, there is a direct link between how much you invest in primary care and the actual outcomes related both to the quality and the cost effectiveness of the primary care. So Dr. Abdullah Khnizan, so we'll be talking about primary care. I just want to have your thought. What is actually primary care? Because it is a term that's been used and can be potentially abused. So let's have a discussion about what does primary care actually mean. You are muted, Abu Ziad.
يعطيكم العافية جميعا وشكرا جزيلا. This is a very important, I think, question that I'll try to go through. But before I go through it, I think this event is really timely, because we know that right now we go with a clear vision, alhamdulillah, Vision 2030, and it's very clear in Vision 2030 that the focus will be on improving the preventive health services, wellness of the population, longevity with healthy aging. All of this cannot be done without good primary care, and that's why we see this reflected in almost all activities that we see in the country. And I think we are, alhamdulillah, in the right direction. We will see, the success of all of these efforts بإذن الله soon.
before we just start, just a quick review of what's happening in our country. I don't know, should we speak in Arabic or English or both يا أبو عبد الملك?
والله both أبو زياد. We have lots of not Arabic speakers.
Not Arabic. Okay, so we'll do it in English. We'll do it in English.
Thanks.
So if you think about it, over the last 10 years, for example, our budget have, this is actually from a publication that we did recently, have almost tripled. Are we gonna do that for the next 10 years? That will be practically impossible, not only for our country, for any other country. And that's why we need to think where is the value and insert and inject our resources into that value, or in areas where we will get the most out of it. And the good news, preventive health services, improving, the wellness of the population, managing chronic diseases is actually the way, and this is very well established, very well proven. And that's why our country is going in this direction. We will be able to increase the budget maybe by 25 to 30% over the next 10 years, but not more than that. And that's why we need to think of the value. And today we are talking about one very important value-based initiative, which is primary care. This is a very well-established concept. What is primary care? Primary care, in our country, we use the words general practice, الطب العام أو طبيب عام, family medicine, طبيب أسرة, and primary care, طبيب رعاية أولية, sometimes interchangeably, which is fine. However, because many countries actually use these terms interchangeably, there is no issue with that. استخدام هذا العبارة أو هذا المصطلح ليست إشكال. However, we are, I think, unique. Our country is unique because, generally speaking, when we say general practice or general practitioner, نعني أو طبيب عام نعني غالبية الأطباء اللي يعملون بشكل أساسي في المراكز الصحية عندنا in the primary care center. Some of them actually work in the hospital in the other specialties, but majority of them work in primary care centers. And those are someone who graduated as an MD, maybe got a certificate or diploma, not more than that. Majority, they are just MDs, and they are working within the primary care centers in our country as primary care physician. And I think historically this is what used to happen and what is happening actually. And I think this is one of the area that we need to improve on, because those are they contributed actually to the healthcare in Saudi Arabia. I have no problem with that. However, we need to change it. I think this is the time to change this. This is not happening in almost like all developed countries. And when it comes to healthcare, I think Saudi Arabia is a level of developed countries, and that's why we need to change this. So in our country, when we should target board certification, and usually the terminology that is being used right now is family medicine specialist or consultant. And I think this is extremely important. There are many initiatives, as you know, that's happening in the country, including the what's happening in the, and I'm a member of the scientific council within the Saudi Commission. The expansion of training that happened over the last few years is huge, and it is actually increasing. This year, by the way, next week actually, on Saturday, the final exam will enroll more than 500 actually primary care family physician actually who will be inshallah certified. At least 450 of them will get the certification based on previous statistics. I think we have good chance to replace those who are not fully board certified into a board certification, and I will talk more about that. Let's go back to primary care. What is primary care? Primary care is a level of care that involve certain criteria that must be there. So we can call it primary care. First of all, it should represent the first contact. the first contact of the population to the healthcare, the gate toward the healthcare. It must be accessible. So it must be, you know, next to your door in terms of your housing or even in terms of your work place. And it must be include continuity of care. This means this physician will take care of you in a longitudinal relationship. Even if he or she refer you to another specialist or a secondary care hospital, still they will be, you know, supervising the care for you and for the individual, and it must be comprehensive. This means that physician will not be just subspecialized in diabetes, for example, or palliative care or whatever, you know, other specialties. So that patient will provide, that physician will provide the biopsychosocial model of care, physical, mental wellness, management of chronic diseases, which is extremely important. And we have to be, you know, we have to talk about, because I always tell my colleagues, sometimes, you know, they get angry on me, that what's happening in our country over years and years, part of it is the part of the issues is issues related to the family physician themselves. Do we have a model? Did we represent ourselves very well clinically in the clinic? Because this is the ultimate goal of a family physician, to be good and to work as a clinician, as a skilled clinician. And to do that, it's not just, you know, word of mouth. You need to be skilled. The training program need to be, you know, at the highest level of training. Competences need to be matched and need to be, you know, reported in a way which is very delicate and very critical. The care also need to be coordinated. So you need to coordinate the care and the needs of this patient with the specialist, with the social services, with the, you know, mental health, you know, support if needed, with the school of the patient, and so on. And it needs to be people-centered. And I say people because we don't need to take care of patient only. So wellness is part of the equation here. And that's why we need to be people and community centered. This is in terms of the definition of the primary care that I would like to work on. And if you ask me, this is a dream, this cannot happen. I mean, many of us who have been trained and worked in another healthcare system. I had the chance to work within the Canadian healthcare system during my residency and fellowship, and I can tell you, I would say 90% of this model exists there. And I worked actually in an atmosphere that practiced 90% of these objectives. Who can work in as a primary care physician? And I think this is also a very sensitive area within our again, when we discuss it among ourselves as family physicians, because sometimes we try to be overprotective of the specialty, in my view. And I can tell you, before I give you the example, I can tell you about our experience at King Faisal Specialist Hospital. We have actually a family medicine clinic, and within that family medicine clinic, we have a full-time OB/GYN, you know, consultant, full-time. She doesn't go to the OR, actually. She's full-time clinic. So she has 8 clinics like all of us. A full-time internist, 3 of them, actually. And a full-time pediatrician, 3 of them. In addition to that, actually, we had 1 orthopedic, actually, full-time orthopedic consultant within our clinic. And we used to have 1 full-time surgeon within our clinic. With time, to be frank with you, we replaced that surgeon with another family physician. But the rest, they were actually good part of the team. And this model of internist, pediatrician, OB/GYN, I'm not talking about the orthopedic, because that was a special, you know, occasion, is happening, you know, and you see it actually within the Canadian model. You see it within the, you know, American model, among other models in the world. So what define a primary care physician? That physician need to be board certified, not a diploma, not you know, just MD. And I will talk about this group later on. family medicine, for sure, they will lead this role, for sure. No question about it. However, I think internal medicine, clinician, they can play and they can enrich the experience of primary care. And to be frank with you, in our experience at King Faisal, we really, utilize our colleague internists, because internists, they have depth of knowledge. A family physician, we have width of knowledge. Combining the two was really a great model that we experienced within our clinic and service. And by the way, we take care of, we see more than 150,000 patients at our unit. So it's not a small unit that we are talking about. Pediatrics also, I think they can work and they can serve as a primary care physician. And this model exists actually in Canada and the United States and other countries. Obstetric and gynecology, especially with the new focus, even in our country, on women's health, improving women's health and wellness of women. When we talk about endometrial biopsies, colposcopic exam for pap smear results, related result and changes, IUD insertion and removal, and believe me, within our clinic we do all of this. And to be frank with you, majority of our female physicians, they did not have a special fellowship in women's health. We utilize our consultant colleague in OB/GYN to train our colleague in family physician, especially female family physician. And to be frank with you, almost all of them, they became very comfortable doing IUD insertion, endometrial biopsy, of course, pap smear, and the rest of it. And to be frank, we have also a small unit within the clinic, which where we can do even colposcopic exam. It's done by the consultant obstetric gynecology. My point is, all these services are very much needed, and our colleague obstetric and gynecology consultant, she actually enriched our experience as a family physician. Of course, we have to collaborate with the whole team, auxiliaries, pharmacists, community health workers, and the rest of it. What about the role of general practitioners? Whether we have to acknowledge that we have a huge number of general practitioners across the board. I was actually looking at the statistics of the yearbook of the Ministry of Health in 2000, and if you calculate the number of general practitioners in our country, will be around 18,000 general practitioners in our country. Some of them they might have some sort of minor certification, medium certification, diploma, certificate. I would expect that majority are just MDs. On the other hand, we have around 1,500 consultants in the whole country. This is across all healthcare sectors in the country. 1,500 consultant family physician in our country. Will 1,500, if we assume that all of them are practicing physician, will they be able to cover the need in our country? For sure, no. That's why we need the rest of the groups who are potential for primary care physician role to be engaged within the primary care, at least for the next 10 years, I would expect, until we will be able to replace the whole population into the whole, population of physicians working within primary care into a board certified family physician, which will be a challenge, but I think we will be able to reach it. So what I'm advocating for, to replace the general practitioners as much as we can. We will not be able to replace all of them, by board certified physician, not necessarily consultant, senior registrar, as long as they are board certified. Internal medicine, pediatric, OB/GYN, family physician, all can work within this level of care. What should we do with the huge number of general practitioners that we have? First of all, for sure, they have significant role and they contributed a lot to our healthcare system. We need to train them and upscale them. And if you look at almost all programs in the world, majority of the programs, I would say Australia, Canada, and other countries, including the United States, you will see other route for being, board certified. We need to explore that for this group, especially the Saudis. So this is one way of upscaling and training this important group of the workers within primary care. Of course, we'll not be able to upscale all of them. I think they still can work as a member of a team led by a board-certified physician within the primary care level. They can, treat and manage minor illnesses, upper respiratory infection, back pain, and these kind of common problems within healthcare. They can also work within clear screening programs, like for mammogram, screening, like colorectal cancer screening with fecal occult blood testing, like the general wellness program. So they can work within these programs. And as you know, Vision 2030 is putting a huge emphasis on these programs with a clear guidance, with a clear written pathways and guidelines that can support their practice. Of course, refill of medication is one venue also that they can contribute to. They can prescribe restricted list of medication, but opening the door for them to practice like if they are a consultant physician when they don't have the competency to do that. This, I think, need to be stopped. We can replace them by a primary care physician from other specialties, board-certified physician, and we need to support them. They need to work within a team, and we need to support them with clear clinical pathways and guidelines when we leave them alone, like to take care of triaging, for example, to take care of screening programs, wellness programs. Of course, we will need some of those to still continue to work within rural areas. This is happening, by the way, in all countries, in the United States, in Canada, in Australia. So this is not abnormal, and we will continue to need them to work in these areas, maybe as independent. However, we need to support them with virtual healthcare services until the time comes where we see Saudi physician replacing and being able to go and cover this area. Health outreach programs also will be a very important part of to support these areas. And I think, support, I mean, everybody's talking about health outreach for subspecialist care and specialist care, which is important. But I think, and to be frank with you, I was exposed to one of the area in our country, I'll not name it, the whole area, there is only one consultant. It's a region, actually. One consultant, a family physician, happened to be non-Saudi. Alhamdulillah, I know that now they have, I think, 4 or 5 consultant family physician, but we talk about a year ago, only one consultant family physician. So we need this health outreach programs to the rural area for family physician. Finally, really, I would like to thank you all, and I want to emphasize that we need skilled family physician, practicing family physician, and we need a lot of them. Thank you very much.
Thank you, Dr. Abdullah. So let me just summarize, Abdullah, so we can, I would ask our panel to feel free to collaborate in one mission. So in summary, Dr. Khnezan summarize primary care actually not a specific specialty rather than and level of service. That scope and level of service need to be coordinated, comprehensive, and I will add competent board certified physician, preferably to be family physician. However, other clinicians that are board certified and competent have a role, like the pediatrician, the internal medicine, and the obstetrician. And he nicely summarized the challenge that we have with a very important part of our manpower in primary care, which are the practitioners, and their right and to be upskilled and trained, and to be, as a country, we have to invest in this talent. Please, our talented panel, unmute and add whatever you feel appropriate. So the floor is yours.
Assalamu alaikum, Dr. Hadi, my dear panels and my dear audience. And I would love to add to what mentioned by my colleagues, Dr. Al-Khnezan. And I think each phase has its own solutions. Probably هذه الفيز اللي احنا نعيشها هذه الإيرا probably need cooperations by other subspecialty in terms of providing primary care to our beloved patients. Probably after 5 years from now, next era, next phase will have different solutions to deal with the current situation. And I would like to add one comment. You know, as long as we don't fragment the primary care services to our patients, pediatrician, obstetrician, internalist, as long as we don't fragment the care, and the primary care physicians, who is family physicians, he is the first encounter, and he's the one who's seeing the pediatric patient, who is the one who's seeing a woman with BV bleeding, and he's the one who's seeing elderly with early signs of Alzheimer. As long as we ensure the first encounter with the family medicine, family physicians, and those other subspecialty would support the services rather than fragmented, then that's great and fine. Hopefully we'll reach a stage after a couple of years that we have enough family physicians to have the proper ratio between the population and physicians. And at that time, the level of care is going to be uplifting, and it's going to have an impact on our patients.
Thank you, Dr. Saad. It's just fact, currently we have a majority of what we call general practitioner, who basically can be a fresh graduate, somebody who just finished the medical school today and then tertium, and tomorrow he's seeing a complex patient. And that similar candidate, if he program the training, I won't let him discharge a URI without coming to me. So we kind of a split in how we approach our patient at the end of the patient. It's a challenge, and the good thing, it's not, we are not the first nation who go through this challenge. I'm sure there is ways of we as different interested group and organization come together to address this issue. I'd love to hear Dr. Amr from the academic side. Your input, Dr. Amr.
الله يسعدكم ويبارك فيكم. And before covering the part related to digitalization, أنا أثني على ما ذكره زميل الدكتور عبد الله عن ناحية إنه we have to adopt the family physician role or family based practice role heavily. To achieve that, we have يعني أول شيء they have to have the needed competences, the needed knowledge and skills that they need to practice. الأمر الآخر resources. if I give the family physician, I put them in a place without the needed resources to practice the idea of family medicine, they will not be attractive for the citizen to come to the family medicine center. المثال اللي ذكره دكتور عبد الله this is one شوي prestigious place in King Faisal Specialist Hospital. Not all primary care center that we have in the country, they have got all of that privilege. Access were there. الأمر الآخر إنه we have to link the population to the family physician. For me as a citizen, إذا ما كنت أعرف مين المسؤول عن صحتي, من my family physician about me, or linked, and I go to him or her directly, regardless the complaint that I have, regardless the place that I have, regardless the sector that I have, ما حينجح المشروع هذا. لأنه there are family physicians scattered in primary care centers across the country. لكن I have the shopping that I can go this time to over here. تلاقي انه احد في قطاع عسكري يروح لقطاع وزاره الصحه، وقطاع جامعي يروح لقطاع من القطاعات العسكريه الاخرى. فthese the success factors for the success factor for the model.
Thank you, Dr. Amr. we spoke, okay, so from the prestigious center اللي دكتور الخنيزان about, let's go to the reality. Head the reality. دكتور عبد العزيز, tell us about the challenges you face في الMOH as of today.
حياكم الله. Thanks for all of the colleague for these thoughts and this discussion. Actually, majority of our primary healthcare centers lies in the sector of Ministry of Health, and I totally agree. Not all the primary healthcare center is well equipped. It is not enhanced. I see the level of qualification of family medicine. Even if we have enough number of family physicians, that it doesn't match the level of infrastructure or the equipment inside the primary healthcare. The other part is that we are talking about physician, family physician, OB-GYN, internist, etc. But we don't have a real national program for nurses, for other allied healthcare services qualification and training. This is what is in my mind for now. Thank you.
You can take us through your presentation, Dr. Abdullah. Let's just Abdulaziz, let's go through it and have what you have to share with us about the current challenges.
Sure. Dr. Abdullah, can you please stop the sharing?
It's stopped already.
It says I can't share. Yeah, okay, thank you. Okay, so the part of my talk is about the challenges that face our primary healthcare system in Saudi Arabia, and mainly I will talk about the MOH that is said earlier. It's around 60%. I wouldn't focus much in the importance, as my previous colleague, they stress on this point. It started early, maybe more than 30 years, 1978, with the Ata Alma Declaration of the importance of primary healthcare. And a few years later, the Ministry of Health has adopted and started the preventive and the curative healthcare services. And they directed to families, individual, and the community. It's a broad spectrum of services, immunization, child health, maternal health, providing the management and prevention of chronic diseases, as well as health education and providing the necessary medication. So in spite of the substantial improvement that happens during the past 30 years, and in the primary healthcare in specific, there are several, levels of improvement that happen in the country. I wouldn't talk about it because it's not the scope of the presentation. There are several challenges that face our primary healthcare system today, and it's more or less mentioned in the previous presentation, like it is the increased demand of the primary healthcare services because of the rapid growth of the population. As you all know, we have now around 35 million population, and we have less number of healthcare workers in general, and specifically the board certified, I would say, primary care physician. The growing population, it is faster than the healthcare services is made in reality. And talking about the workforce capacity, this is a study was done by Dr. Al-Asmari and his colleague. And as you can see, the number of nurses is outnumbering the other healthcare worker, including physician and other allied services. And even looking into the current figure 2020, the numbers are more or less the same. Again, we have new initiatives by Ministry of Health along with the Saudi Commission. They have several programs, health coach program, health case coordinator, and etc. But I don't see anything related to nurses qualification, which is a major challenge in the environment of primary healthcare. In comparison of practicing physician among other countries, the Saudi Arabia lies in the lowest, or I would say, we have a low number of physicians as compared to other countries. However, it's a global challenge everywhere. And when we talk about family medicine physician, as you can see in 2019, we have only around 1,900 family physician, certified Saudi family physician. We depend on the non-Saudi physician, our colleague, and the total number in the country is around 4,000. When we calculate it with the number of population, we are way beyond the benchmarking, the global benchmarking, which is between 2,000 to 2,100 for a panel, which is again a very great initiative by Ministry of Health, the team-based care. The cost of healthcare is rising everywhere globally. However, if we compare our healthcare expenditure, the country is spending less compared to other developed countries. And again, there is an important issue here, which is the healthcare expenditure goes to the secondary and tertiary care, and the primary care is not receiving the enough resources and equipment. Since 30 years ago, the chronic diseases prevalence is not that high, as we can see in this study done recently and published recently this year in May 2021 by Dr. Kbis and her colleague. It was previously the communicable disease, the infectious disease, and now it is shifting toward the chronic disease. As you can see, the prevalence of diabetes is around 23%, hypertension is around 18%, and dyslipidemia is around 50%, obesity and overweight is around 80%, and finally the central obesity, which is a main link with the metabolic syndrome, is around 74%. However, these chronic diseases, as you can see, around 50% of them, they are uncontrolled, and we need a highly competent physician to work very hard to overcome this issue. One of the major challenges actually in the primary healthcare that we are facing now is we lack an efficient health information system. We have many health information systems like موعد, وصفتي, علم or واحد, very fragmented, they are not integrated, time consuming, and even sometimes distracting for the patient. I know there is a national initiative to combine all these, and the situation, inshallah, will be improved in the future. It's a major, as we all know and agreed, even in fancy centers like King Faisal, we have a success story, and we can implement it, in our primary healthcare system. And in my opinion, the major investment will be in HI system these days. Of course, it will give the physician the up-to-date information, and it will be a cost-effective. In my practice, I can tell you that when we order labs, it can be repeated in several institutions, and it is very highly costly for the country. It is an unsensible cost that is not really calculated. And then there is a simple solution. When we combine these together, integrated system, it will be noticed and solved, inshallah. Again, the referral system, it's a major issue. The rate of referral back now from the specialist is only 30%, and the evidence indicated that if we have a good referral system, we will reduce the outpatient visit by around 30%, and you can imagine how much the cost will be. And it's a vicious cycle. If we lack the good feedback, we will have inappropriate referral, and the cycle goes on. Of course, we all know the importance of feedback. Even for the GPs, they can learn, they can communicate with the specialist, and they eventually implicated in improvement of the service. This is the first part of my talk. Thank you, Dr. Hadi.
Thank you, Dr. Abdulaziz. You raised two important challenges. The one is the care of chronic patient, and which is increasing, the burden of a chronic disease is increasing. You also mentioned one of the challenges with the virtual care, both of which are on our agenda. So Dr. Maha, let's hear about what do you have to tell us about the care of a chronic patient in the primary care and module of care.
Alaikum. Actually, I was listening to all of the presentations, and I'm glad I'm going to be at the end, because when I'm thinking about primary health care, I think of the doctor, I think of the patient, I think about the environment, and I think about, when I say the environment, the resources, the rules, the regulations, everything, and the society. So nowadays, actually, a lot of the patients we are seeing many people with a lot of complicated conditions. It's not common cold anymore. People are not coming to the primary care for common cold. It's a very, very low percentage. Most of them are coming with diabetes, hypertension, hyperlipidemia, other conditions. So the cases are really complicated. And what is done now during the transformation, and it's still going on, and we are improving, there is a lot that has been done that improved the services. How much? Still, I don't have figures, but I can see that we are more empowered. At least for me, the online services is a great thing that was done for primary care physicians. It's convenient, it's more satisfying to the patient. We can reach a large number of people who can't come to the primary care. They can call just for refill or for advice. So what I see, the family physician has the biggest and the largest burden on him. Personally, as everyone was speaking, we want to do this and we want to do that. And me, myself, as being a family physician in the Ministry of Health, I was thinking, how can we save and protect this family physician in order to be capable of delivering all these good services and all the services that were mentioned or is going to be applied in the transformation. Most of the physicians, still, I didn't bring any statistics during this presentation, but most of the physicians, I can say like up to 60% people I meet are not satisfied, the physicians. They feel overwhelmed, they are stressed, the number of patients is a lot. In the clinic, you get to see on average 50 patients, and most of them, I can say out of 10, 7 are very complicated cases. And still you work, I'm not talking about Jeddah and Riyadh, of course, or Dammam. Let's talk about the periphery, where the primary care centers, they are good, but they need to be better. I personally think in order to go forward for family medicine and to apply it properly and to support the family physician, the Saudi family physicians, I still think we need the GPs, whether they are expat or whether they are Saudis. Of course, our aim would be to train and to help them advance in providing the medical care, but I wouldn't say that I would love the family physician to be responsible about everything, because we do need collaboration. We do need the health personnel, not only nurses. We can use the nutritionist, we can use the social workers, we can use a lot of people. As I will talk, I will be mentioning in my presentation, even the case manager could be a health worker who's not a nurse, for example. He could be someone who's trained to help. We cannot put all the burdens on family physicians. They're getting burned out. I'm not going to talk now about motivation. I'll leave it to the end. But at least for now, this is my thoughts just for discussion. Thank you so much.
So I will come back to your presentation, Dr. Amma, but you mentioned important challenges that it will take to know what, let's go through what's actually the potential KPIs, what will make the enable us to tell what's the primary care, good primary care will look like. Dr. Saad, you have a strong background in health management and diploma in healthcare quality. can you share with us metrics and KPIs to measure the primary care? They want to come back, address the challenges by Dr. Maha.
Okay. Well, now we are, as a physician, we are good in terms of approaching patient and clinical, and we are trained as family physicians to address the patient in the whole holistic biopsychosocial. But when it comes to numbers, sometimes we get scared. Today, I'm going to share with you a story, and just the reason behind it, just to simplify the concept of KPIs. Now we can upscale and downsize this story to different levels. Now, our colleague Ahmed, he's in charge of a medical center, and in his medical center, he provides the core services of primary care. He's providing urgent care and booked clinic, antenatal care, chronic disease for diabetes. Let's say they have laboratory services, and they have the pharmacy, which is the basic things in a primary care center. Now, our colleague, Dr. Ahmed, in spite of all the meetings that he's doing, yet he still receives a lot of complaints from unhappy, unsatisfied patients. So he's in the office trying to manage his admin work, yet every now and then a patient knocks the door and telling him that he had a bad experience or complaining about something, which is almost all the admin probably experience that at a stage of their administration. So the concept of KPIs was introduced. KPIs, it's quantifiable, so it's not subjective. It's not just feeling or impression. It's a number, and you measure it, and you measure your performance, and it is progressive, so it is over time, and there is specific objectives. So in order to check your performance and how well you are doing in treating your diabetic patient, or how well is your supportive services that are provided by the nurses or the pharmacist or provided by your colleagues, doctors. But before you do this KPIs, you need to know the concept of it. Now, when you choose a KPI, a key performance indicator, you would keep in your mind, you would choose something with high volume because you are dealing with many patients. So you will check something like in the pharmacy or the lab or an outpatient. So these are high volume. You will think about KPIs that is measuring a high risk that has a zero tolerance of it, like fall or error in dispensing medications. You have zero tolerance for that. You don't want to have any fall in your center. You will try to check a KPIs for something potential to be a problematic, something it could be area for mistakes in terms of documentations, in terms of units, in terms of wrong administration of certain medications or allergy to certain medications. So you want to measure that as well. And of course, you will align your KPI selection with the institutional strategy and with, if there is accredited body like SABAHI or international body, you want to do KPIs once. You don't want to do a KPIs for accrediting body and another KPIs for yourself, another KPI for your institution. So you will align all of that. And in general, KPIs, it's either measuring the process, what you are doing, or measuring the outcome. So our colleague, Dr. Ahmed, heard about the KPIs, tried to implement it in his center. So before he's doing that, he needs to write the objectives. What are our objectives for each services? He conducted a meeting with his team, and they did the brainstorming and a full day workshop to get out objectives for each services. Now, keep in your mind, we are doing this for simplifying the idea. It could be more complicated. Now, one of their objectives that any patient registered for urgent care should be seen within 30 minutes, because this is a hot area. We could basically have bad deterioration of the case if we postpone or delay the response to those patients. So that's one of the objectives. The objective that they choose in booked care, that they notice they have a lot of didn't show up patients, didn't attend patients. So they want to decrease that DNA from 50% to 10%. So they will do certain project initiatives to ensure that the DNA is less than 10%. Because as you know, DNA costs money, DNA costs an appointment for another patient who might need it. DNA is a wasting time. Antenatal care, they look at the antenatal care that they are provided, and they want to have at least 4 visits for the pregnant who registered as a pregnant in the first visit for the last 12 months. So 4 visits per 12 months means good follow-up are provided by the antenatal care. They look at the chronic disease, and they have chosen outcome KPIs. They want to have a control for at least 80% of patients who's following with them for the whole year. Now, they have to define what is control. They have to define what age group, and controlling could be different from a person who is 38 or 40 in comparison to control for a patient who is 75 with comorbidity. In the lab, do you want a waiting time less than 30 minutes? Anyone registered for the lab, he or she shouldn't wait more than 30 minutes to get these services. And the pharmacy, they want a 0 dispensing error. So they will do initiatives, and they will do an action to ensure no one will receive a wrong medication. Now, these are objectives. The KPIs, it has actually a full form, while numerator and denominator and definition and explanation of each KPI would be written in that form. But that's again for the sake of simplifying the example. So, is the KPI always correct and accurate? It's debatable. It could be misleading, actually. The example that I'm going to give, Mr. Ahmed or Dr. Ahmed, our colleague, is still receiving patient who's complaining from waiting more than 1 hour in the lab, although the scoring that he has, according to the KPIs, it's 25 minutes. So is the number incorrect, or is there something wrong? Actually, the number is correct, and the KPI needs sometimes further sub-analysis. Now, as you know, the KPI is measuring the average time. So they will take the time for the patients, and they will take the average, and they give you the average 25. But as you know, most of our patients came for the lab in the morning, they are fasting, so they will wait for 1 hour in the morning. While in the afternoon, maybe the waiting is less than 5 minutes. So if you take the average, it is 25 minutes, but again, you didn't reach the goal. The client is unhappy because the waiting time more than 1 hour. So sometimes you need to have a further sub-analysis of your KPI to understand the meaning of the KPI. And you need to interpret it within the right context. It's unfair to compare a KPI in a small center with a KPI in a tertiary hospital, or a KPI in a primary care that provide the basic care to a primary care that provide probably psychiatric care that need further waiting time, further consultation times. So the benchmark and the comparison should be similar, whether it's national or international. KPI need discipline. KPI is not one-time thing. You need to do it either weekly, monthly, yearly, and see your progress with time. You see your trend. You challenge yourself with the score that you score this year, and you and your team try to achieve better in next year. Again, KPI is not about individuals. It's about an institution. It's the performance of the institution. It has nothing to do with the individuals. So our fail going to be on all of us, and our success going to be for all of us. So again, KPI is a tool. You could use it or do it, but has no impact on the patient. KPI should lead to something called informed decision. Now, Dr. Ahmed, when he sits with his teams, they have numbers, they can challenge them with the numbers, they can initiate a new project, quality project, to improve their performance. They will have something they talk about, a dashboard. Then they might do another project to improve the services that they are providing. So basically, these are a simple idea of what's the KPI. I encourage myself and all of my colleagues, and even those who's in training programs, to get familiar with these numbers, with the quality project, the KPIs, because we as family physicians, we are a manager, we are a leader, and we need to interpret the right numbers. Thank you.
Thank you very much, Dr. Saad. Now, so far we have been in a journey from why primary care to what is primary care, who can work, some of the challenges, some of the KPIs to tell us on the track. Dr. Amr, maybe it's time to give some, share with us some enablers on or another venues to provide primary care. It's all about virtual these days, so the floor is yours, Dr. Amr.
طيب الله يسعدكم ويبارك فيكم. Thank you. I will talk about the digital aspect or the digitalization aspect. So what's the impact of the digital transformation of the primary healthcare? And the digital health has been we talk about it for decades over here. During the pandemic, it has been accelerated. It was not initiated, but it was accelerated. Previously, that most of the we talk about digitalization or informatics or health IT as enabler to enable us to provide the required primary healthcare per se or healthcare in general. Then the new technologies that we have and emerging technologies, the fourth industrial technologies such as the robotics, artificial intelligence, and the mobile health that we have, the augmented reality, has drive the primary healthcare to a further level, and sometimes that it has been disrupted the primary healthcare that we have. To start with, I don't have got any conflict of interest to declare, and these are the contents that we will cover briefly. So we'll talk about the cultural digital penetration in our society and the healthcare transformation in general in Saudi, and some of the standards and governance related to the telemedicine and data governance that we have related to the health sector, and then how to comply with these requirements on the primary healthcare level, and some of the national digital health projects that we could see, and some of the primary healthcare digitalization use cases and the digital health workforce development. So by history, that's as we taught in the medical schools, this is the traditional way that we are supposed to take it, to deal with in general with our patients, to take the history examination of the investigations in the clinic or in inpatients or in emergency, to come up with diagnosis or differential diagnoses list, then to have a management plan and follow up. And that has got its own limitations, and that's why that the physicians has been called in Arabic in many cultures as the Hakim, because it's the only source of the medical knowledge. We have the Pendleton, as a family physician, we have the Pendleton model that has been published for the first time in 1984. Let me hide the panel. Okay. that has been moved the consultation model to be more patient-centric, that we have got shared understanding of the problem, number 3, and the shared management plan, number 5 over here, and to maintain the trust and the relationship between the physician and the patient. And that has been empowered our patients to know more about their, not just to pay and to comply with the patients, with the physician's orders that we have. This is the oldest slide that I have in my presentation, and I like it so much because it shows the movement of the physician-patient relationship across the history. Previously, that the physician here up in the holy landmark of the land of the knowing, that giving order to physicians and the physicians to the patients, and the patients, they have got to pay. So take 2 in the morning and don't ask questions. But we found that when we educate our patients through the health promotion and health education programs, that will be more adherent to their management plan, and they will take care more about their health. And that's the movement toward the health education. However, with the access to unorganized sources of medical and health related information, that we lost the control. Our patients, our society, they have got access to medical advices across the WhatsApp groups, across Twitter, social media. One of the main problems that we found currently during the pandemic is the many patients that are hesitant to take the COVID-19 vaccine. Why? Because of some of the tweets and social media against the vaccine, and that not only during COVID-19, previously that we have. And that's why WHO mentioned that one of the major killers across the globe is the hesitancy to take the vaccine, and mostly through the social media. That's why this is the first time of the history of medicine that both physicians and patients, that they have got equal access to the information at the same time. I remember when I was a medical student, second-year medical student, at that time, that if we want to retrieve information from the PubMed or Medline, that we go to the library in the first floor, and we ask them to give us CDs of the related citations to ask. But in 1997, the PubMed has been open widely for anybody, and the search per year jumped from 7 million per year to 120 million per year at that time. If you have gotten access to PubMed, so physicians, they have got access to PubMed, Medline, Ovid. They just Google and find. Many of our patients that they diagnose themselves through Google before coming to the clinic, and they are coming to us as family physicians, or we are supposed to be the first contact with the patients. They come to us for second opinion, or sometimes they know the diagnosis and they come to you because they want free medication. They want the prescription from you. What we are supposed to do, that we have got hand in hand to guide the patients to the authentic, updated sources of information, and to provide that. As we are supposed to prescribe for our patients medications, we could prescribe for them authentic social media account about their diseases. We could prescribe for them some health mobile apps. I already diagnosed myself on the internet. I'm only over here for a second opinion. In Saudi, we have got the new model of care that we have. Previously, we talk as primary care as the first layer to provide healthcare. That's not correct anymore. We are not the first layer. We are the fourth layer, and behind us that we have, or above us, that we have the secondary and tertiary care. But if we look over here, that we have got the activated person and activated society, or healthy communities, that we have health in every policy in the government, in the country, in education, في المساجد, في الأسواق, that we take care of health. After that, directly is the virtual care. So patients that they have could be triaged and could be diagnosed or triaged through تطبيقات مثل صحة وتطبيقات خاصة الكيورا وتطبيقات أخرى that available. It could be directly to patient to physician or health coach, or could be through artificial intelligence and predefined algorithms that we have. But we have to govern that to avoid the drawbacks of the wrong self-diagnosis and wrong self-treatment. So we have the virtual care as a layer before primary care to provide health to our society. Digitalization has been this model of care is empowered through 42 interventions. 3 of them are directly related to digitalization. We have the integrated personal health record for the patients. We have the virtual self-care tools and the virtual education and navigation tools. Let's talk about the dimension related to the digital health penetration in our society. Globally, that the internet penetration rate is approximately 60%, and the social media users are around 50%. And in Saudi, we have 95. This is January 2021, and it has been affected a lot during the lockdown during the pandemic. That's the jump to 95% of our population between 16-year-old and 65-year-old. They are using internet at daily basis, and almost 80% they are active social media users. The growth has become 4.2% with the internet users, and the 8% among the active social media users. I put that slide. That's the in our populations approximately, or in average, that the time spent using the internet is around 8 hours per day, and social media use is around 4 hours per day. So we have to seize that opportunity. Previously, I can tell the patients to give them pamphlet about their disease. Currently, we're supposed to give them social media, prescribe for them social media account, authentic social media account, and we have to play a role in that as family physicians through our societies. These are the most common websites that they are our population, our target population that they are looking for. And mostly that they are using YouTube, WhatsApp, Instagram. Facebook is in the 4th level, while it's globally it's the 1st level. If we look over here, that use of mobile by category, 95% they are using for chatting, such as the WhatsApp. 95% they are using as for social networking, such as the Snapchat. However, around 40% they are using their mobile for the health, fitness, nutrition apps. It's a shame that when I have a diabetic patient in the clinic and I use a smartphone or iPhone, and the patient using a smartphone and iPhone, and we don't connect to each other, and we don't empower that digital platform that we have for the sake of the health of the patient. And we ask, what's the home glucometer readings that you have, and they share it through papers or notes. It has been increased during the pandemic. Around 65% of our population that they are using online food delivery service, such as the Jahez, hunger stations, and previously we ask them about the fast food eating and the healthy food during the healthy lifestyle modifications. But currently, that's in the same house, in the same family, that each one of the family members, they are ordering from different delivery options that they have. And the costs are around 1.5 billion, the total value of the online food delivery marketing. A published study that with medical students that we have in 2017, That's the in 2015 among diabetic 2 patients looking for their online health information seeking behavior. Many of the patients are around at that time 48%, although that most of them there were above 50-year-old. The average was at that time 48 during that sample, and almost 40% of them, they were looking for their health-related information related diabetes before coming to their family physicians. And this is the impact of online. This is the main source of information among online seekers and non-online health-related information seeker. Still, we are as physicians at that time, at the time of the study, we are the majority, that's around 77% of the non-online health seekers, that their family physicians were the primary source of information, while 50% of the non-online, the online health information seeking behavior. Most of our patients, they look for Google before coming to their physicians, then Twitter, then Wikipedia. Then, for example, for diabetic patients, they are looking for the موقع الجمعية الخيرية لرعاية المرضى. We are not comparing between the social media and emerging technology and artificial intelligence. We compare it with the brain of physicians. We are comparing between physicians that they are assisted with the technology and physicians that were not assisted with technology. These are some examples of the emerging technologies that we have that disrupt the way that we provide healthcare in our community. Telemedicine and the smartphone applications, the wearable devices and sensors, reading the genome, searching for the natural language processing, and the social media and the electronic health record, the virtual and augmented reality, the automated image interpretation using the AI. We have now a national program of the mammogram readings and diagnosis directly through the automated image interpretations, the interventional and robotics, predictive analytics and big data analytics using the AI, and writing the genome that we are not, but many of these, especially telemedicine and mobile health apps and the artificial intelligence, are applicable and could be utilized at the level of the primary healthcare. Wearable devices. Most of all of our patients, the majority of our patients, they have got health apps in their iOS or Android platforms that we could utilize and integrate to empower them, taking care more about their health. أبو عبد الملك، في وقت كافي عرض الفيديو هذا؟
I think we can save it for Abu Abdurrahman, just for the sake of the time. I want to go through.
Okay.
We can conclude with it if we have time. So thank you very much. I want to go back to Dr. Maha. We've been through a journey with lots of enablers, lots of KPIs. Tell us about the complex patient, what we are currently doing and what we are going to hope to do in the near future.
Or to comment?
Your presentation, please.
Okay. طيب، بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I will repeat saying that I'm so honored and happy with what I've heard from my colleagues, and especially the presentation of Dr. Amr Jamal, because I think the way forward in medicine, I believe, as Dr. Maha, IT helps a lot, and digitalization and using all the technology helps family physicians and doctors in providing the best possible care. And I am sure also it leads to patient satisfaction, as I mentioned before. and using the applications. And like Dr. Amr said, the patient, he's not coming for me. I'm not the first line. Actually, there are different lines before me or different levels. He's doing it digitally. He's giving his weight and height, and he can do a blood sugar reading and send it to the application, and they will give him a diagnosis, and he will come immediately saying, Doctora, I'm a pre-diabetic, how can you help me? So I think digitalization is a great thing in medicine that will help us go forward. Actually, my presentation is just very simple because I am into discussion, and I thought I'm not going to repeat what my colleagues have mentioned, but one of the paragraphs that interested me in the Vision 2030, which is, there is a lot of paragraphs and there is a lot of programs I do admire, is the program aimed to restructure the health sector in the kingdom to be a comprehensive, effective, and integrated system that it is based on the health of the individual and the society. So we do care about the individual and the society, and under the society, I would like to put a line. The society, we as doctors, I remember when I first went into family medicine, the book McQueenie, and they had like a big building and there was water leaking and people were busy wiping the water, but you need to find the source of the water. So this is when we talk about promotion and prevention. But here I am talking now from another perspective, which is the society and the collaboration of different sectors and organizations. If we do a lot of care for the patient and we talk about obesity and we talk about weight control and we talk about diet and even about treatment, if we are not supported by the other organizations in the society, we don't have support from special communities, we don't have a system in the agriculture, what they call it ministry, or in the food and drug ministry also, or society. But now, we're having some moves that I like the food labels, the calories in the restaurant. Now it's mentioned, so people are aware what are they putting into their mouth. Now it's very clear. Everybody is, not everybody, but some are walking. Our country now is going into more open spaces, providing people the opportunity to walk and to enjoy that experience in order to help doctors deliver the best care. IT, I'm not going to repeat the training and the curriculum of the family medicine. Actually, the curriculum of family medicine, it's updated and it's moving with all its objectives and helping implement the vision of 2030. And I'm proud to say that the curriculum of the family medicine is a good curriculum, and actually it's a great curriculum, and it's just the implication that will help it to be even better and translated on the reality. The complex care, everything was mentioned in the model of care concerning this group, the chronic care, but as we see, it's a complete cycle, and it's the complete ultimate objective of the well-being. We do not work alone. If you want to deliver complex care, we need a multidisciplinary team who is trained as good as family physicians. I cannot function alone. We are not alone. We are a team, and we are all equal in providing that care, everybody according to his role. The case manager, which is very important to me, and I would give it, I would give some details to it, and the IT system. And what's the evidence? The evidence, there are so many studies, and some of our colleagues mention it, the patient satisfaction, the better control, increasing the life expectancy of the citizen in Saudi Arabia, and the quality of life. I think part of the social and the physical well-being, we are seeing some qualities of life are changing in our country, in our society, that will lead to also increasing our happiness, which will lead to our general well-being. But let me go with you to some of the slides, and then I will talk more about my idea. So when we say complex care or complex patients, there are so many definitions, but I found this one, which is by the Agency of Healthcare Quality. It's the person or the persons with 2 or more chronic conditions where each condition may influence the care of the other and are commonly cared for in the primary care. The complex care, as we can see, and all my colleagues actually are mentioning parts. We talked about nurses, the GP, the pharmacist, telemedicine, tertiary care, spouse and relative. We didn't talk about the family, the neurologist, the other specialist, but also we are talking about, I would like to add, the society as a whole, the groups, the supportive group, like what they call it, the Alcohol Anonymous. We need support for drug addicts. We need support for mental health. I'm talking about just not your everyday group, which is just on paper. I want real group with real input and output, where you feel secure to exchange your information and under a supervision or under the observation of a psychologist or a trained family physician who can facilitate the discussion going on, because you cannot rely on the family physician to do everything. We are trained and we are equipped. We do a lot of counseling, and we love to do it. I'm talking at least on my behalf, but sometimes you're overwhelmed with the load and the time, and you tend sometimes to say to the patient, come on another day, which is not very often where you have time to counsel and to support. So patients with complex care, as I was mentioning, they need a lot. When we talk also about complex care, what about the mental health? We have a lot of people who need mental support. They have stress, they have depression. Here is the role of the social workers in the family primary care centers. We need them. We really need them. They help us. And at least you can start, they follow, they can form the groups, the supportive group. But also here, I would like to add the media. People, like Dr. Amr said, we spend a lot of time on our apps and mobiles and whatever you want to read. I'm not judging, but I'm sure you have this experience. I have a group. I have like 4 groups in my family, and they keep adding me, and I keep on getting out, because you know what? They're stressing me out. Why? They keep on adding false medical information, and they just listen to some magic recipes. I wonder from where they get it. And I tend to correct that piece of information in a nice way, either by recording my voice, either by putting evidence, and I go into translating even the information. I swear, wallah, I finished that within half an hour. Another lady will send something which is totally the opposite of what I said. So how can we use the media to make it more attractive to the user, especially from the medical point of view, that they can use it for their good and they can follow? Because I'm just overwhelmed with how people are following people on the social media. I'm not going to mention names, but I'm not going to say an influencer. I don't believe for this term, I limit it only for special people who do good. But some of the people, the celebrities on the media, they use one word and they become so famous, and people go to them and pay money and listen to them. And other people who care about...
Dr. Maha, if you can conclude your presentation in 2 minutes, just for the sake of time.
Yes, sure.
I know it's going to take us for us the frustration with the media. So just for the sake of time, if you can.
Sure. 2 minutes, I'm done. Sure, doctor. So the conceptual framework, we have organizational factor, and we have individual factor, and we have interactional factors. I've talked a lot, but the organizational factors, I'm going to leave it to discussion. There is a lot that has been done, but there is still more to be done. And on the individual factors, the programs are doing a lot, the family medicine programs, but maybe we need to think of other innovative or creative ways that could empower the family physicians. So coming back to the case managers, the case manager, he could be, as I said, a social worker or a nurse. He doesn't have to be the physician, and he needs training. We cannot just assign a nurse that would do the role without any training. So we really need to focus on training so she can help the family physician to do his job. And this is some of the skills needed, which is also needed by the family physicians, by the way, and we do train family physicians on all the skills mentioned here. So I'm not going to talk again about e-health because Dr. Amr has spoken a lot about it. The evidence, people say that when you give complex care a good chance and you apply it, it's a better outcome, better treatment, better compliance, satisfaction, and greater continuity of care across all different care settings. And this is also mentioned in the model of care, but it led also that to the end result that patients are happy, satisfied. I'm not saying 100%, and the life expectancy is increased from 72 to 75. This is where we're talking about the well-being. I think all of us, or some of us may have, but the health sector transformation program delivery plan is a great resource to look at it. And I conclude my slide with this reference. Thank you so much for listening, and thank you, everybody.
Thank you, Dr. Maha, for a very informative session. You know, it has been a very interesting journey so far. We kept something very special to the last. You know, we heard about lots of frustration about the primary care, about the limitation of the challenges that face the family physician. I'm going to share with you a very interesting story that happened in our practice. In our practice, they run breast-Guinea survey for all physicians, family physician, internist, dermatologist, plastic surgeon, every single physician. And for 2 years in a row, the winner of the best across all the physicians, we have around like 350 physicians, tend to be a family physician. And for 2 years in a row, it tend to be the same family. So we told you there must be something secret. What's going on? Why physician 2 years in a row, despite being in a busy clinic, caring, demanding patient, get the highest breast-Guinea survey, all the other fine subspecialists. Dr. طارق Bunhaya, tell us your secret.
ابو زياد يضحك، اعتقد يقصد نعطيهم فلوس.
اللي يعرف طارق ويعرف شخصيته ويعرف نفسيته he knows why. الله يعطيك العافيه.
من طيبك والله يا ابو زياد، الله يحفظك. شكرا بعدنا لك، وانا حقيقه very enjoying a lot من الدسكشن والموجود. والمشكله ان البرزنتيشن سهل، يعني الكلام ان احنا نقدر نعطي تعابير بالسهله، سمايلينج وهالاشياء دي كلها
الحقيقه عندي برزنتيشن بتكلم فيه، بس انه يعني I will share my experience اكثر حاجه من البرزنتيشن. يعني انتم عارفين ان البيشنت always satisfaction is very important. يعني it's good indicator حتى for quality و good indicator حتى البيشنت retention وحتى الكلينيكال outcomes. لما نجي الموست امبورتنت اسبكت في البيشنت ساتسفاكشن، نلاحظ ان احنا از بيزير، يعني عندنا مثلا والدكتور سعيد موجود از ماي تشيف، النمبر اوف بيشنت عندنا والديماندنج زي اي مستشفى ثاني يكون فيري هاي. الشيء اللي يساعدنا يمكن احنا ان السيت اب حقنا كويس، ان في عندنا يعني almost 80% I can say continuity of care. يعني you have your own patient assigned to you which is always your patient. They build up your trust, they build up a relationship بينك وبينهم بشكل كبير. هذا يخلق جو من very important. يعني أكون told you many times the story، يعني إن a lot of our patients, they came from inpatient. When the cardiologist told them, you need a cardiac cath, he told the cardiologist, wait, give me half an hour, then I will be back to yes or no. What the patient do? He will come to my office or the family medicine office, knock the door, ask him, cardiologist asked me to do a cardiac. What do you think? So he gave me a trust. This is a trust to me rather than somebody else. In addition to that, today I have patients came from nephrology clinic. Ask me the medication given to me by nephrologist. What do you think? Do you have to take medication or not? This is a build up of a trust. It's not an easy. It take maybe time, لكن it will come with the time. So very important to build up يعني for the visit of the patient comfort measures. يعني احنا always يعني تكون available to your patient as much as you can. مثل ما قالوا الفيزيشن الأطباء الأخوان والأخت الكريمة الدكتورة مها، إن السوشيال ميديا الآن خلت في easy to communicate with your patient. يعني some whatever type of communication, either you keep the patient on WhatsApp with you or through the emails or through my chart, whatever the system. Just the patient sometimes ask one question. This question will save his visit to come to the clinic. Medication you start to him get side effect, you will answer the medication. Just he ask you one question, you answer it. This will save his life, save visit to the hospital. This is very important. You're available to your patient. Number two, you need to develop a rapport. يعني sometimes احنا because of the busy clinic, when the patient came to your clinic, always you ask him ايش مشكلتك, what's the problem. You didn't at the beginning, like a few seconds, you build up a relationship with him. You ask him how is the way, كيف الطريق, عسى ما في زحمة, هالأشياء دي كلها. هالminutes هذه البسيطة, الseconds هذه, build up relation, good rapport with the patient. يعني خاصة إذا كان patient he trusts you, he knows you very well. أو مثلا تسأله what's happened before last visit, how was everything in the last 2 months, كيف الرحلة. خاصة بعض المرضى يقول لك إني مثلا سافرت فتسأله كيف كان الفيزيت. هذه كلها تخلق in the few second rapport, تخلي المريض feeling, يعني يقل discomfort حق المريض if he want to listen from you bad result ولا good result. Sometimes in name, يعني بعض physician or staff they use the name patient like it. يعني أنا ما نبقى against الخالة وعمة, لكن دائما be careful with even الخالة والعمة, لأن بعض الأحيان بعض الأخوات ما يرضون إنك تكبرهم لما تقول خالة أو عمة. فأنت احرص قدر المستطاع you find out with the time إيش النيم اللي the patient like it. يعني مع الوقت حتعرف إيش الأشياء اللي يحبها مريضك مقارنة بالأشياء الأخرى. Make the patient feel comfortable, very important. يعني السيت اب يساعد المريض. ما تكون غرفتك معفوسه. انا ممكن السيت اب مو كل مكان يصلح, لكن very important حتى لو كان minor سيت اب تخلي المريض يحس more comfortable. Very important, I can feel it, I can see it. إن كثير من الستاف talking to the patient while he's standing. Standing معناها يلا خلصني بسرعة, ما عندي وقت. You can use standing behavior مثلا في emergency room, في urgent care, there's no time just for one point. لكن in your clinic with your patient as a visit patient, you need to give him a time. Sitting is very important. خاصة if you talk with him about bad diagnosis. Treat the patient if they are part from family. Always I say this one. There is, for example, old Baba, you need to treat him as your father. يعني حس مكان الأب هذا لما يجي. لو كان أبوك في نفس مكانه, لو كان أمك في نفس مكان الوالد اللي بتجي, كيف أنت you treated the patient مقارنة لما كان أمك ولا مكان أبوك أو أخوك, your brother or your son. you treat him the same. يعني لأنهم the patient is seeking a help from you. فهو جاي يبي he want a help. تخيل one of your family he want to help. You try to give him the help as much as you can. Number 2, very important, effective patient communication. طبعا أنا I'm sure إن most of our staff ما شاء الله it's good for communicate the patient, good communication with patient. بعض الأحيان في tricks معينة. Always إحنا we don't maintain eye contact. Very important ترى. A few seconds هذه you maintain eye contact with the patient rather than using the computer or using the folder. هالثواني هذه كلها is very important to the patient. يحس إنه في أحد يسمع له، يحس إنه في أحد give him the attention at least for a few seconds. I know الكمبيوتر الآن very important، لكن it's very important حتى to tell the patient with wording that I will look to your result. عطني بس ثواني أو دقائق أشوف النتائج حقتك وأرجع لك. هذه الأشياء السمبل تحس في المريض إنه he's here. He's not just أنت بروحك وهو لوحده. It's very important to express a concern over their symptom. Important thing. أنا لاحظ حتى مع my colleagues they use terminology المريض ما يفهمها. Always try نخلي very simple terminology. لا تحط لا don't think المريض انه يعرف حتى مع التكنولوجيا والاشياء الامبورتنت المرضى يجون باشياء information. Still the language very important. Use non-medical language as much as you can عشان المريض يحس انه he can understand it what's going on with his problem. Number 3, third element, which is the decision sharing sharing decision making. احنا من المشاكل اللي احنا لازمنا عايشين فيها اللي هو paternalistic approach ويعرفون الفيزيشن you act on the behalf of the patient. Always I told my patient when there is for example a result medication I will use it I will ask him what do you think. يعني بعض الأحيان بعض المرضى يقول لك okay this is your الدكتور أنت اللي تعرف وأنت اللي تعلم بس still you sharing the decision is very important. المريض تحس إنه معاك في التريتمنت معاك في الادفايس فهي share with you his idea his concern. some of our patients we use for example dyslipidemia we ask him take Lipitor يقول له دكتور الله يعافيك أنا ماني ماخذه واحد من أقاربي أخذه وتعب. فأنت you just listen and give him what's the problem. ليش تعب؟ لأنه صار في مثلا side effect مو كل مريض يجي side effect. هذه الثواني اللي هو sharing experience with the patient is very important. Receiving a new diagnosis of or an update always frightening المرضى. المريض لما البيشنت لما يجي يكون حاس يعني he want a part of reassuring وإن كان البارت بعض الأحيان في الباد diagnosis ما هو كبير لكن يحتاج إنه جزء بارت من ال reassuring عشان he feel more comfortable when he talking to you. Very important end up with few questions. صحيح لما تقول للمريض مثلا هل عندك أي سؤال بعض الناس يقول يفتح مجال أكبر للمريض إنه يسأله. أنت try to answer these questions at the beginning حتى المريض يقدر يفهم إيش اللي قاعد يصير. حتى لو if you mention to him you have any question not necessary to resolve the question now. You can tell them okay next visit we'll solve the problem we'll solve these questions we'll answer them in detail because of the time. Very important. I use it always with my patient. Writing documentation to the patient. يعني مثلا مريض I change his medication ما أعتمد على الكلام. This is my own way. I don't depend على wording. Always I write a paper to the patient. I give him what is medication, what changes will do, how you will do. حتى لما يكون caregiver موجود أقول له we'll increase the dose of insulin. أكتبهم كلهم عنده. فالمريض يحس لما يروح البيت يحس ما في confusion. وكذلك استخدم يوز الاشياء معينه. الان you will go to the lab you will go to the pharmacy and you will go for مثلا x-ray ولا whatever. I am trying to use writing documentation for small paper. This will help some of our patients but that are old patients so he can understand what's going on with his problem and future problem. Very important always when the most influential factor on patient customer satisfaction, it found out the medical staff's service attitude. So our attitude as healthcare staff with the patient, it will help a lot to improve the patient satisfaction. And always my other colleagues, they told me, your patient is very appreciated. ممكن يكون some of our patients is very appreciated. لكن believe me, that our patient is smart. They know exactly who is taking care of them. من هو اللي يعطيه أكثر more attention, more اهتمام أكثر compared to the others given medication and discharge. They will know with the time who is taking care of them, whom they want looking so hard to resolve their issue as much as they can. By this, I end up my presentation. I hope you enjoyed the presentation, even very, very small.
Thank you very much, Dr. Tariq. It's truly very enjoyable, though it's rushed for a few minutes. Such presentation, we need a workshop. Okay, so we are coming to the end of this. I know there is a few agenda items that we did not cover. I just want, before the audience leave, on December 17 and 18, we're gonna come back to you with full conference addressing all these issues in more depth, in more discussion. And I'm inviting our guest speaker today to please join me again on December 17 and 18. We're gonna do a joint program with the American Academy of Family Physicians to address these critical questions. So what you have seen tonight, discussed briefly, we're gonna dedicate a full 2-day session with our expert. I just wanna hear one take-home message from each of our distinguished panel. Dr. Abdullah Zan, one conclusion or take-home message from your side.
Thank you very much. What I want to say, what is being implemented في التخصصي أو في أرامكو, I think it can be implemented elsewhere. لأنه I'm talking about primary care level. We're not in the family medicine or primary care at الأرامكو التخصصي. We don't use البيت سكان والسايكلون والكيموثيرابي. نتكلم عن access to good health information system, qualified physician, access to the common medication and investigation. And that's it. مرة أخرى يعني الدكتور طارق I would add, أنا يمكن هو ما يبغى يقولها لكن أنا بقولها, I would add إنه all of this competent physician, practicing physician, skilled clinician بالإضافة إلى الفيتشر الأخرى اللي وصفها. بدونها you cannot score high, you cannot deliver the right services to our patient population. يعطيكم العافية.
Thank you, Dr. Amr.
الله يسعدكم. My take-home message that the emerging technology as a tool that we have in our hand as a physician and our patients, we have to utilize it to promote health, to empower our patients. The new term, patients are not anymore consumers of the health. They are prosumers, professional consumers that they have gotten access to the same knowledge that we have. So we have to utilize the technology for the sake of the health promotion. Thank you.
Thank you. Dr. Saeed.
Thank you, Hadi. And I think primary care would remain the the gatekeeping access to healthcare. And I think all of what has been said, even including technology, are enablers to the family doctor, to the practicing doctors. They are good enablers. I agree that patients are currently becoming more educated and more exposed to different kinds of health information. But the role of family medicine is becoming more even important, I think. In the old days, it's a lack of knowledge. Now there is too much knowledge that confuses the patients. I think it's better that patients are better off having little knowledge, not rather than have too much of knowledge that confuses them. So I think that the role of family doctor will have that. And I think the game changer in the future will be our future family doctors, our graduates from residency program. They are the one who are going to change the whole game for the healthcare in Saudi Arabia. So I think the future is bright, and it's an opportunity now for us as a family medicine, as a primary care. It's our prime time that we have to utilize, and if we didn't catch this moment and this momentum and this chance, then we lose it.
We will make it happen, Dr. Saeed. We will not lose it. Dr. Abdulaziz.
Yes, Dr. Hadi, thank you, all of our colleagues. I think just to be fair, we are doing good in the level of primary care, but the effort is a scattered effort. It wasn't concentrated in one primary health care to show the effectiveness of family physician or other allied healthcare services. And I'm sure, inshallah, we are in the right direction with the vision of 2030. And within the next few years, inshallah, we will achieve ideal primary care in our healthcare system.
دكتور مها.
طيب أول شيء من جد دكتور هادي, thank you so much for inviting us and giving us this opportunity. I'm so honored to be today with all of my colleagues and all of the attendees. Thank you so much. And I'm thinking, I always say to myself, ask yourself, why did you pick family medicine from the start? And this always ignites my passion and my motivation. And it keeps me going. And actually, I talk with passion about family medicine. So always remember what brought you to be a family physician. Try to motivate yourself. And if you can be a force of change or an element of change, do speak and do give your opinion. Thank you.
Thank you. أبو زياد, دكتور طارق.
ما شاء الله, I don't want to add anything, but يعني I hope what had been said today it's going to be implemented. لأن كثير من الأحيان هو نتكلم we talk لكن implementation is not an easy. ودكتور سعيد, remember في Aramco at the beginning we have very difficult to make assigning patient to the family medicine. It take time from us. لكن finally has been done. So مثل ما قال دكتور عبد الله, whatever كان موجود في كل مكان ما كان موجود أصلاً. It take time حتى ويحتاج more of implementation practice أكثر.
Thank you very much. Ladies and gentlemen, it's the end of the day and still I have more than 2,000 in the attendees. I want to make sure that you are aware of very special الأمسية من أمسيات طويق that's going to happen on January 5, 2022. So we're going to hit the year 22 very hard with a very difficult and important conversation on the 5 Bs. Are they complementary or the contradictory? The public health, the population health management, preventive medicine, and the primary care. Where shall we orders? Are they complementary or contradicting each other? And as you know, December 17th and 18th, we shall run a very intensive 2 days course to go in-depth discussion about all these critical aspects that we have discussed. There are lots of very important questions that we raised in the question and answer, and I'm personally taking note of all these questions from whatever the medication restriction that been asked, what to do with it, from the comment regarding the top-notch centers versus the regular center, or the role of pharmacists, etc. All these questions will be addressed during the conference. I want to leave you with a message. We're at the stage where it's not talk, it's an action. We're at the moment of and executing. Walking the talk is not anymore a PowerPoint presentation and the story. I want to leave my dear colleagues across the nation, whether you are a family physician, we need very proud of having you. If you are happen to be a general practitioner, we see very critical, important member of the family, and as a nation to come with a plan to make the best use of your talent, to help you the best you can to help us in the transformation. By this, I come to the end of this evening. Thank you very much. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa barakatuh. مساء الخير.
يا ديرة العز والمجد التلي يوم ابو تركي رقا للمعنى